Welcome to Research Perch from the Massage Therapy Foundation. Short, practical insights into massage therapy research and how it can benefit your practice.
Hey everyone, welcome back to Research Perch from the Massage Therapy Foundation. I'm Michael Reynolds, co-chair of the Massage Therapy Foundation Marketing Committee, and as always, here with Ruth Werner and Nikki Monk. Ruth, how are you?
I'm well, Michael. It's good to see you again.
You too. Joining us as always, it looks like from your beautiful home on the coast of Oregon, right?
Yes, lovely sunny day today. So
Looks awesome. And Nikki, how are you? Joining from your office in downtown Indianapolis?
I'm doing well, thanks, Michael.
Good to talk to you both, as always. So thanks to everyone, as always, for joining us again for this podcast, whether you're watching by video or joining via audio. We have lots of formats for you. If you're watching the video, click below if you want to take us with you on your phone. And if you're joining via audio, you can always grab us on the blog via massagetherapyfoundation.org as well. So let's get started. So as usual, we take our content from the IJTMB, which is at ijtmb.org, the International Journal of Therapeutic Massage and Bodywork. And today we have an article titled Report of the NIH Task Force on Research Standards for Chronic Low Back Pain. So this one sounds a little bit different than what we normally talk about. It looks like it's, first of all, it's got the word task force in it, which sounds very action-oriented and powerful, and like things are getting done. So tell me about this task force on research standards for chronic low back pain. Who'd like to start?
All right. Well,
you go for it.
Okay. All right. I'll give a start. And so this, Michael, you make a really good point. This is a very different type of article for the journal, but it's a really important article. This is a task force that was created by the NIH, which of course the National Institutes of Health, their pain consortium. And the reason they did this is because there's a lot of research out there about chronic low back pain. Chronic low back pain is a very important condition. It's a very prevalent condition. And for our purposes, it's also one of the main conditions that folks utilize complementary alternative medicine, such as massage therapy. Also, and I think it's second behind chiropractic care in the CAM modalities. So it has a lot of pertinence, and I want to note that this particular report is a reprint. This is a report that has been disseminated through several different journals, and so I'm really pleased to see it showing up here as well, because it certainly does hold a lot of pertinence for us. And the big piece that the reason that this whole task force was created and charged with what they were charged with is because there is a lot of research out there, but it's really hard to compare the different kinds of interventions that are being looked at in research, because people aren't necessarily defining chronic low back pain the same. They're not measuring the same things. They're not being consistent. And so this task force was charged with setting up research standards specific to chronic low back pain. And this is also specific to research, not for billing purposes, not for clinical treatment purposes, but specifically for research purposes. So is that, so Ruth?
Yeah, that sounds pretty useful.
Yeah, there we go.
Yeah. Actually, what just happened was everything froze.
And so you logged off and then came back on. Okay.
Hey, you're back. So we're good. So welcome back, Ruth.
I just finished the whole discussion, Ruth. Not really.
Awesome.
We're all done.
I just gave a brief introduction, and so I've made a couple of notes to myself to make sure that I was hitting all these different pieces. And so the different things that they highlight about the varieties in studies, the various pieces in the studies, is that there's variable inclusion criteria and exclusion criteria. The definitions for low back pain and chronicity and reoccurrence are not necessarily the same. Right. The baseline assessments are hard to compare. There's stratification criteria. So you have chronic low back pain, but is all chronic low back pain the same? Not necessarily. How can we differentiate? And then also what sort of outcome measures are important? And so these different variances pose challenges. It's very hard for there to be epidemiological comparisons across competing interventions. It's hard to replicate.
There's no way to compare apples to apples the way that the research is currently being done. And so you get a bazillion small-scale studies, and you can't really draw any conclusions from them because none of them really.
Even large-scale studies. And that's the problem, is
Yeah.
you can have all these large scale studies too, but because, well, these are completely different patients, or these are completely different measures, so we don't know how this particular intervention compares to this completely different sort of intervention. It also makes it hard to pull data, to resolve conflicting conclusions, and develop consensus across disciplines. So this large group was charged with getting a set of standards together. And I tell you what, working in these sorts of task forces and other groups, all of us who've worked in groups know how hard this can sometimes be. Sometimes like herding cats, right? But I think that these folks really show a nice example of seemingly very clear steps taken, and they've made very clear suggestions and support for their suggestions. This is a really great article and pertinent for us. While not a whole lot of folks are doing the kind of intense chronic low back pain research, like in case studies and things like that, but knowing these pieces, we can start integrating these into how we are asking questions with our clients and patients. So, Ruth, do you want to talk about how they went about the stages and the recommendations, or do you want to just jump right to the recommendations?
Well, I want to back up for a minute, and hopefully this is something I can just talk about while I was offline. But one of the things that drove the creation of this task force is the recognition not only that chronic low back pain is common and extremely expensive. I think they estimated $635 billion with a B dollars a year in direct and indirect healthcare costs. A lifetime prevalence of 39%. And most of those people will have it as a recurring, sort of long-term problem. But the other thing that really drove this was the observation that more people have back pain than ever before. More people are getting care for back pain than ever before. Various kinds of interventions, surgery and pharmaceuticals and manual therapies and other things. Still we are seeing an increasing number of people reporting having their lives limited by low back pain. And what that means is those interventions, something's not connecting. They're not working well, right? The fact that people are using more interventions than ever and the numbers of people reporting low back pain are higher than ever means that something isn't connecting well. And so, in order to find out what really works, there needs to be a way to look at the research and be able to compare these different population groups and whatnot. So that was a driving factor here, which I think is, a great observation and really brilliantly done. The other thing I noticed is that they actually had a model to base this on. A similar task force was done, and I didn't catch the year, but was done to look at temporal mandibular joint dysfunction, to create some commonalities of language, diagnostic criteria, and treatment descriptions, so that they could know, when some research on TMJ disorder was presented, that it could fit into this standard. So, did you talk about some of the standards that they recommended setting?
Well, so that's the next step here. So they did the next thing. Yeah. So they did a 3-stage process. And so the first thing that they did was they just identified the key principles that they all wanted to agree on, and sort of the different things that they're charging themselves with doing or being charged with doing. And then the second piece that they did was
let's define.
Oh well, yeah. So
let's define they.
Oh, they. Oh, okay, great. So this is the task force, right?
Yeah, I mean, they. I'm sorry, we're having an echo issue. But they is representatives from all these different departments at the National Institutes of Health, including what was then NCAM, National Centers for Complementary and Alternative Medicine, and now is NICI, National Centers for Complementary and Integrative Healthcare.
I would love it if it did, but we'll see. Nobody listens to me.
But also, the branch of NIH that deals with arthritis, and the branch of NIH that deals with inflammatory diseases and the brain, all these different branches of the NIH had representatives informing this task force. So this wasn't just about CAM therapies.
Well, and they have a list of the task force members as well, which is really helpful, and it talks about their expertise. And so in their first table, they give the co-chairs, which I think both of them were involved with the TMJ task force too. So they had this, they had that background. But then they list out the other task force members and their expertise. And while there's somebody here from chiropractic and epidemiology, there's no one here that's massage therapy per se. However, I do note that there is somebody from the Churkins group up in the Group Health Research Institute up in Seattle that was representative on this task force. So, and his specialty was epidemiology. So lots of representation here from orthopedic, rheumatology, musculoskeletal radiology, internal medicine, physical therapy, all manner of folks involved with their expertise. So, but yeah, we have a nice list of the membership here and their affiliations, and they're from all over the place. So really nice representation there.
And so they met in this initial meeting, the step one.
And step one, and then they identified the key principles. And so I'm just going to go over a couple of the big ones that we start seeing in the recommendations. And so the first piece was being able to figure out how to identify chronic low back pain and get a definition that we can say, okay, this is what we would expect for chronic low back pain. And then also, given the state of knowledge, being able to stratify chronic low back pain by its impact is going to be more feasible to do this if we look at it in terms of pain intensity, interference with activities, and physical function, rather than a diagnostic code. Okay, so that piece. And another key thing that they identified was getting a minimal uniform data set. And so that everybody who does research on chronic low back pain needs to be reporting on these minimum pieces at baseline. And then also what sorts of outcomes are we going to be looking for, okay? And so those are the things that they were tasking them. They actually list out 12 different items, but I think those are the key principles that were developed for, especially for our purposes today. So once they established this, the next step then was to everybody come to a consensus about what was going to be the most important thing. But here again, how do you do that? There's a list of like 20 people or something, and so what they did was they broke it down by medical diagnoses and histories, and then they did by self-report functional pieces. And they did a survey and sent it all around, and then had everybody rank the things by import. And then once everything was ranked, they actually put together a very handy dandy in our table 4 in this article. They give the recommended minimum data set. And it's a series of 40 questions that cover everything from the demographic, health behaviors, and some of these functional pieces.
Treatment history there.
Right.
Yeah, so that every report that meets this standard will be able to go and find out, okay, what was the age of the people that you worked with or targeted? What was the demographic group? What were their health histories like? Because we couldn't depend on having that minimal amount of data available in any given study previous to this.
Right. Exactly. So
the foundation is working on creating a similar thing. We're calling it, I forget, gosh, now I'm going to be in trouble because I don't remember the acronym, what it stands for, but it's STRICTUM. And it has to do with minimal things that we want to see reported in any kind of research about massage therapy.
Right, and that's research in general. Right. And so that's what this table 4 is doing, and this is in addition to, and we'll see here in just a little bit what their actual recommendations are, because they do identify specific demographic pieces, but that comes in the 3rd step, which we're probably ready for at this point. What do you think,
Yes.
Ruth? Okay.
Oh yeah.
So they give a total of 6 big recommendations from this task force, and we can go through these. The first 3 really have to do quite a bit with that recommended minimal data set. Okay, and so the first thing was, the recommendation was to describe the chronicity of low back pain, And so they have a couple of questions that's on that questionnaire, but basically it's low back pain that has persisted for at least 3 months and at least half of the days of the last 6 months. Okay.
Such an elegant way to draw the line in that sand.
Yes.
You
Yeah.
know, you can get a definition of low back pain through asking 2 questions. How long has back pain been an ongoing problem for you? And how often has low back pain been an ongoing problem for you in the last 6 months?
Right. And so
And then the answers to those are very cut and dry, define whether someone meets this criterion.
and there's a picture to show this is the region that chronic low back pain lives in, right? And notice here that severity is not part of this definition.
Right.
So it can be, you know, kind of minimal, but it's consistent, it's persistent, right?
And it can be niggly that flares up once in a while.
Right, right. And so this is where later on we start talking about the stratifying it, right? Stratifying it. And so we'll get to that in just a minute. Oh, that's number 2. So recommendation number 2.
Stratify by impact.
Right, by impact. And so it talks about the different items that are included in that questionnaire that are going to contribute to the stratification, but they're able to do this by mild, moderate, and severity scores. So now we've got 3 different ways that we can identify. We've said it's chronic low back pain that meets this criteria, and here's the level of that chronic low back pain. Okay. The third recommendation is the things that you need to report on this minimal data set. And so these are the things like the demographics and the physical exam and things like that. So from a demographic perspective, behaviors, smoking status, obesity, substance abuse, widespread pain syndromes, those are all necessary. The history, comorbidities. Yeah, right. The history of surgical interventions and opiates, those are the things with the history perspectives that are required. Interestingly enough, the physical exams ranked pretty low with everybody. However, there were a couple that showed as being best, and so like the straight leg raise would be good, especially for folks that are experiencing chronic low back pain with leg pain. Hip rotation, particularly for older adults to rule out arthritis, and then lower extremity strength. But that these 3 pieces aren't necessarily expected and required for everything. Okay. Interestingly enough, no labs or imagery were indicated, and you know, part of this is because the evidence is really weak here.
And those of us who specialize in soft tissue therapies, you know, we know that that's true. And now it's you know, that an X-ray or even an MRI sometimes doesn't give us information about where the pain is.
Right.
And
or their perception of the pain.
Amazing to see this really sort of be more widely recognized by the mainstream community, isn't it?
Absolutely. So now they do say that even though there's no lab tests or imaging that would be required, they do say that the MRI is the most valuable potential test, and that it should be required for really invasive procedures like surgeries. And so that would be a requirement for that sort of research. Now they also identify self-report pieces, and the things that are most important here are going to be physical function, depression, sleep disturbances, and our favorite, catastrophization. Right. And so what is catastrophization? It's basically the extent to which somebody is, oh my gosh, this is the worst thing ever in the world. And how
overwhelmed by their pain.
Right. Yes. Yes. There we go.
Yeah. And that, you know, leads back to something we have talked about in other research, Perches, which is sort of the transference of what might be an occasional painful experience to chronicity. When our central nervous system actually physically changes and makes us more sensitive to pain. And we call this central sensitization. And, you know, one of the things that this task force has done is to further sort of codify pain as a condition as well as a symptom.
Yes, yes. So moving to the next recommendation number 4, and you guys are going to hear things that I've been talking about quite a bit in our Perches with this one, because now we're looking at outcome measures. And so with outcome measures, they don't necessarily say everything has to use this outcome measure, although they are highlighting the promise measures, that they have this great repository for measures that are the psychometric properties are high with these pieces, but they're talking about when you're looking at outcomes that have continuous measures, that not only should the means and standard deviations and the change scores be reported, but also the proportion of participants that are achieving certain thresholds, or, my favorite thing, minimally important change, clinically meaningful change, right? And so they suggest that in general, a 30% improvement in pain and function could be considered clinically significant, but there are other, some measures like the ODI, the SF-36, things like this, do have clinically meaningful changes, the minimal changes that exist with that. Go ahead.
So I want to back up for just a second, Nikki, because we've used several acronyms that probably we should elucidate.
Oh, right.
So the first is PROMIS, which is PROMIS, and it is, I wrote down in my notes somewhere what that stands for, but basically it's a group of measures having to do with patient-reported outcome measures IS.
I don't remember.
I forget.
That's basically it. Yeah.
All right, anyway, so that's what PROMIS means. And then the other acronyms that you just gave us had to do with questionnaires for pain and function. The OWS.
The ODI is the Oswestry Disability Index, and this is a specific
Oswestry Disability.
And this is a specific measure that's validated in chronic low back pain specifically, so it's pain with disability. The SF-36 is that's the one with the physical function quality of life measure, and so that's a big standard one as well.
Good, just so that people know.
Sorry.
So the next thing after
doing it.
Outcome measures. I'd like to speak to the next couple of these. The numbers 5 and 6 of the recommendations.
Well, let's finish the outcome measures because there's two other pieces here. And so one of the other pieces that they talk about is the composite outcome measures. And so this is actually rather than just having one thing happen, it's a series of things that have to happen in order for clinical success to be achieved. Okay, and so this would be so improvement in pain and function and global self-assessment.
Yeah, I love that.
Okay, so there's that piece. And so what this does is it defines success in clinical terms, not just statistically relevant terms, okay? And then the last piece that they talk about, we're looking at chronic low back pain, a chronic condition, and follow-up needs to be done 6 to 12 months is going to be the preferred piece.
Nice.
Yeah, so there's the recommendations 1 through 4. Ruth, pick it up with recommendation 5.
All right, I'll pick up 5 and 6. So number 5 is the recommendation that we need now research using these proposed standards so that we can test their validity.
Yes.
So essentially what this read like was a call for grant proposals to do research on chronic low back pain with the agreement of using these proposed standards that the task force has put together so that we can, test how well they work. Because talking about them, it all sounds very sensible and straightforward, but we don't know what the pitfalls are until we actually try to put these into practice. So that was, a very important thing, that to create these recommendations doesn't just stand there, it needs to be tested. And one of the opening statements about this whole process is that these standards are intended to be a dynamic document that will grow and evolve over time as we learn more about what it takes to gather good data about what works for chronic low back pain.
And that dynamic piece is so important.
Right.
I'm glad you I'm glad you lifted that out.
Yeah. And then the last piece was about dissemination, and this is what was really interesting to me because this report appeared in the International Journal of Therapeutic Massage and Bodywork, and the word massage is not in this report. It does not specifically address massage therapists. There's a reference to manual therapies as one of the ways people sometimes choose to manage low back pain. but I was curious about why this ended up in our journal, and I went and did a search for, just the title of this piece, of this document, and in fact, it is in all kinds of journals for all kinds of specialties.
Yes.
Our journal, the International Journal of Therapeutic Massage and Bodywork, then has been called upon to be a voice for the National Institutes of Health to the massage therapy community to recruit people to do research using these standards, or to recruit people to demand that researchers use these standards so that we can use their results, more satisfactorily. And that made me very proud that they chose us to represent to the massage therapy profession, the call for these improved standards in reporting research on chronic low back pain.
Yes.
That's really all I had to say about this. So.
Well, I'm the big dummy here. I thought these standards already existed. So I'm the one that's like, really, these standards didn't already exist? So I learned a lot today, actually.
Well, yeah, I mean, and people were doing some aspects of these, but it wasn't being done consistently. And the group, the folks that we give buy-in to and that had buy-in for, hadn't come to a consensus about it. And now it's out there, and now we're going to test it out and set this as our expectation. So it's an important piece of work. I second Ruth's pride in having it showing up in IJTMB. It's a great place for it to be.
Yeah, absolutely.
So I understand the concept of what's happening here, and then I got lost in lots and lots of terminology and things I wasn't familiar with, which I appreciate you defining. But that always prompts me to ask, what does this mean to the practicing massage therapist? What does it mean to them?
Well, it means a lot of different things. And one thing is that we're going to know as we turn towards research, the research that's going to be coming out, that there are consistent pieces that we're going to be able to take our massage research that's focusing on massage and compare it to some of these other treatment options. Whereas before, the research that's being done in massage with chronic low back pain, there's actually quite a bit of it. In fact, of the conditions, that's probably one of the most that's been looked at, especially with the larger studies. But it's hard to compare it to other interventions at this point. So hopefully that's going to get better. And then a second piece that I find really interesting is, while these standards were not designed for clinical practice, however, we could start asking our clients about some of these outcomes and seeing how it's showing up in our practice. And so when we do see case reports, when we do see small practice-based studies, that they can be compared across these other pieces if these sorts of things are being collected. And so some of this is stuff that we already collect in our intake forms, but it wouldn't take a whole lot to include some of these other pieces to give more of a context of our clients. And then we can relate it to the research that's coming out.
So when you say other interventions, that means things like maybe medication or other types of therapies?
Surgery, chiropractic care, acupuncture, other things. Mm-hmm.
Sure.
Implanting nerve devices. I mean, think about the people who live with low back pain. And one of the frustrations is even those really super invasive interventions don't seem to get great results.
Mm-hmm.
And I think it's great that the NIH has decided this is unacceptable and we need to take a closer look at this and gather some really good information.
Well, and so
it sounds like it is.
And part of this too is the fact that we are trying, in medicine and in healthcare, we're trying to figure out the most effective and affordable or cost considering interventions that are helping people, right? But until you can really do
with lowest risks,
right, and until you can really start comparing the different interventions, it's hard to know those things.
Right.
Yeah. All right. Well, I can see how this very much moves the profession forward. So this is exciting stuff.
Mm-hmm.
So, well, thank you both for sharing, as always.
Thanks,
and
Michael.
As always, we always encourage our readers and listeners and viewers to go grab at least the abstract, if not the entire article. Hopefully the entire article at ijtmb.org. We'll link it below in the blog. And if you're listening, remember to go to ijtmb.org. And for this one, I would search for task force. It's probably one of the ones that'll pop up near the top. And again, report on the NIH Task Force on Research Standards for Chronic Low Back Pain. Look for that one.
Well, yeah, and this is one that you really want to access this one because it has all the meat in it. I mean, you don't get the questions and stuff just by looking at the abstract.
Yeah. So go get it. It's free.
Mm-hmm.
Yeah.
So, well, thanks everyone for joining us as always. Nikki, Ruth, thank you so much as usual, and everyone who's listening and a loyal follower of Research Perch, we really appreciate it. So, if you wouldn't mind, if you're an iTunes listener, do us a favor. It would really mean a lot to us if you would go to iTunes and just take a couple minutes and leave us a review. It really means a lot to us, and it really helps Research Perch rise to the top in the rankings. More massage therapists like you and more researchers like you can find it and benefit from it. We really just a couple of thank you for joining us. Again, we're on line at massagetherapyfoundation.org, and the journal is at ijtmb.org. So until next time, thanks again. Thanks, Nikki. Thanks, Ruth. We'll see you soon.
Bye now.
Bye.
Thank you for joining us for this episode of Research Perch. Please send feedback or questions to perch@massagetherapyfoundation.org. See you next time.